Okay, briefly, how RNFA versus APRN RNFA billing is different. So if you have two people, one's a RNFA, one is an APRN RNFA, same person that goes on to school, for example. I mean, nothing different about them and their skill set, what they're doing, simply that one of them has an APRN after their name. So what's the difference? So the RNFA billing, very unique to every state. Okay, so this is for the most part across the board the same everywhere, except there's a couple states here and there that are totally different, that require different things. And I'm not going into the weeds there because that's a great time to go check out Gary Hargreaves After Hours. That's his world. But that said, CMS is kind of think about the donut hole. That's kind of where First Assist would call like their donut hole, where nothing happens. It's just like, oh, there's no donut here. There's no money to be made. It's the CMS patients, which is Centers for Medicare and Medicaid Services, which is basically all of your patients that are in that age of usually 65 and older, or they're disabled, have end-stage renal disease, kid care, whatever it is. Those are the patients where if you're a First Assist, I hope that you are a prescriber. Otherwise, you're not going to be able to see billing for your services in most cases. All right, so this is the bummer about being a nurse First Assist. If you can be a nurse practitioner First Assist, you can bill for those patients, okay, in most places. Now, commercial insurance mostly will allow RNFAs to assist and get billed, and bill for their services, except for CMS patients if it's an assistable case. And if you go through the NIFA program, one of the things you get as a resource is a guide to basically which cases are used for kind of like the most commonly done cases. You can like search for CPT code on this nice PDF, and it'll show you this is rarely, sometimes, and always assisted, like say a bypass surgery, almost always going to be assisted. How are you going to do a case like that without assistance, right? Whereas you do like a port removal, well, you probably don't need to assist for that, right? And somewhere in the middle is a gray zone, and that middle gray zone is where you have to have someone looking out for you. If you're the first assistant and you're not an APRN and you're trying to justify your billing, you need to have somebody that's at the surgeon's seat documenting, saying, hey, I needed this person to help me because this is a complicated case. This patient's not your typical blah, blah, blah. They had this wrong and that wrong and this wrong. We had adhesions, we had bleeding, we had what? You're justifying your behaviors. And that's what they have to do to justify you. And on your end, obviously, you have to reciprocate that by billing and doing a little blurb as like a perioperative note, and then submitting it to billing. It's not exactly difficult. You have to have an NPI and all of that to be billed, and you have to get some insurance coverages. But again, it's not a hard process. Talk to Gary Hargreaves if you want to learn more about it. NIFA Billing Company is a great resource if you want to consider doing some freelance work and just do your own thing. Point being is there are a lot of different steps in the OR for who can do what and coverage. It all boils down to your insurance product, what you're allowed to bill for, and then a big part of that comes down to what NPs can do versus PAs and all that. APRNs are able to bill in all 50 states. So the one big thing here is this is where the CMS patients and commercial patients kind of come together. You can bill for both of those now. So for me, if I'm working on a cardiac surgical world, I mean, almost everybody is 60, 65, 70, 75, somewhere in that range. It's all adult geriatric. And that's where bypass surgery happens for most people, not everybody, but for a lot of people. And for most of my patients, if I wasn't able to bill for CMS, that'd be a problem, right? That wouldn't make a whole lot of sense. So that's where it comes into play, where you can say, hey, I can add value to being part of this team because I can bill for my services as an APRN RNFA, where that RNFA can't, or that STFA, they can't, or if they can, it's just going to be a very small amount. So do realize that there are some variability in what APRNs can do state to state. That changes seemingly daily. You would want to talk to the hospital-specific credentialing body and ask them how they bill for your services, what they allow or don't allow, as far as being an NP, what specialty, what hospital. There's a immeasurable amount of variability there, where you just have to say, like, hospital A across the street from hospital B, they may be totally different even though they're across the street. So you have to talk to the hospital and say, hey, what are you guys cool with? In the end, it boils down to your insurance. Will they pay for you or not? And liability, will you be covered or not? And that really boils down to interpretation. PA is a little different. PA, pretty much they're good to go anywhere you want to because they have a linked license to their delegated relationship to a physician. Now that's kind of changing. There's lots of, let's say, legislative talk and efforts being made right now to try to let PAs have the same uh, autonomy that nurse practitioners are gaining, seemingly state by state, month by month. I think there's over half the United States has full prescriptive authority available in their states for nurse practitioners, because we know the quality of care we can provide is equal, if not better in some instances, than with physicians. We always know about referral capabilities, and physician assistants do the same thing. It's just that they have a different relationship, so the AMA doesn't hate them as much as they do people that think that they're going to be in a full practice role. That's a lot of uncomfortable energy when you have to think about it like that. So PAs haven't really been in the gun sight so much as NPs have recently, but they're putting themselves in the gun sight. So my point in all that is to say, they were there for us when we wanted to get full practice authority. Make sure you stand up for the PAs because they deserve it too. They do a fantastic job. All right, so what does this all mean? What's the point of this all? So think about, we talked about kind of the life, the different things about it, the aspects of the job, maybe some jobs you like, some jobs you don't like, how that world works, how your billing is. So what's the point of kind of putting it all together? So in my mind, if there was one thing you could do that'd be really important is to put that all together into this slide. What do you do when you're in that scenario? Okay, so let's put myself as the example here. Scenario is you finish your NP school and you find out that there's an opportunity to do what I thought was my dream job in CV surgery. Okay, kind of a funny aside, I interviewed for family practice and CV surgery at the same time. And I was doing FNP, right? So as an FNP, I'm doing clinic-based care for these patients and had a fantastic experience. The physician that did a lot of my training was who I consider a very good friend at this point. My wife, who's also a nurse practitioner, she ended up working with him for, I think, 3.5 years. Fantastic human being. If I couldn't get the job in CV, I would have been happy to work with him. I've been honored to work with this guy. But at the same time, if I had my druthers, I'd rather be in CV surgery. Let's be honest. That's kind of what I wanted. But I knew that was probably a long shot. It was about a year before I finished my school that the person that was in the role actually was a PA, and I was going to hopefully fill their shoes. And that was where it became like hey, are you willing to wait a year for me to show up and help? It's a long time. It's a lot for everyone else to ask, but they did. And I was fortunate that they gave me that chance. Not everybody has that opportunity, and I get that. I will say this is kind of where you say, like, what do you do, right? So you're about to interview. I understand that not everybody's going to have this as laid out as this, but I work with these patients. I already knew the team. We had a great relationship. I got to do clinicals with them, and then I go to interview, and now they're treating me a little different because now I'm walking in the room and I'm going to say, hey, I can operate at this different level. I can be a nurse practitioner. I can prescribe, I can diagnose, I can do these things. And they're looking at me saying, okay, well, that sounds great and all. So what do you need to be successful? And I was like, I'm not exactly sure what you mean by that, except that, in the back of my mind, I had already had conversations with a person who was leaving the job. And the biggest thing they said is make sure you are trained properly so that you're going to be an asset. So don't be bashful to ask for training if you don't already have it. So as an FNP, I didn't have that training. I had some of it just kind of coincidentally. I had to do some time in the OR. That was an opportunity to me while I was kind of on the job training, just additional clinical hours above and beyond the minimum required. And one of the things that came up was I want to get trained to be in the OR because this position, the person that's leaving was an OR person. So I said right up front, I want to go to NIFA. This is the best program. I've done all my research. This is the most universally accepted process for APRNs going to the OR to get caught up to speed, to learn how to suture, to get their hands, and to be competent. And anywhere I go, I don't have to worry about people saying, where did you go? Never heard of them. It can be, you went through NIFA? Oh yeah, got it. You're good. You've been through that. You're set. So that was the way I started the whole conversation with them. Plan for a training. And I can tell you, this is a big deal. I know a lot of people that say, well, I don't want to bring that up in the interview, but I do want to go to get trained, but I don't want to, tell them I haven't been trained yet and then have them wonder if I have to pay for it, or they're going to pay for it, or maybe they're going to pass me up because, whatever. A big part about this is realizing you should worry about this before or during the interview process, because if you don't, they don't know the expectation, right? It's like a first date. You go on a date with somebody, you're just getting to know them, they're getting to know you. And if it's a mutual click, Then it goes to the next level. You have a second date, and the second date is now when they give you the job offer. And once they've decided that they're into you and you're into them, and then you say, yes, I want this job, but here's the deal. We need to have a conversation about what a long-term relationship looks like. It's like, man, I'm not ready for that talk. But in this case, you're saying, well, you want me to be around for a while, don't you? You want to pay me to do this job. This is what me being successful looks like. And that means that I need to be trained for this. Now, there's two schools of thought on this. One is get your training before you go into that interview process. Why? Because that way you already have the training, you know you can already do it. Now, the other flip side of that is that would require you to pay for it all yourself, right? And then you're a broke student, you're going through the expense of getting, more clinical time, you can't work as much, you've cut back on hours, school's expensive. I get it, right? So it's not a great time to be spending more money. Now, the flip side of that is you wait until they are going to hire you for a role. I didn't need to be an RNFA to be in family practice, but I did need that to be in CV surgery. So I said, hey, this is something I need for my job. And I know that you probably don't want to pay for this right now, but if you're willing to plan for this expense, make this a capital budget expense for next capital cycle, plan for me to go to this training so that I can be successful and walk into this job and be here a long time and know what I'm doing and provide the best possible care. And they said, sounds good, let's do this. Not everybody has that experience, but I will also tell you plenty of people didn't negotiate that. And then what ends up happening is because it wasn't set up front, they're like, well, if you want to go to the OR, you're going to have to use your CME money for that. And you're going to have to take your own vacation time for that. And that's kind of the game that's being played, because a lot of people will go through training and then decide they want to move or do something else. And then they got trained for free, basically. So it's pretty common to see hospitals saying, okay, we'll train you, we'll pay for that, but you're going to owe us 2 years of time, or you're going to whatever, everyone's a little different with that. So point being is realize that when you go through this, the training is going to take time and money, not just money, right? It has a cost for your hotels and your vacation time and the airfare and the course itself. Yeah. That's one thing. But the time you have to invest into this is a big deal. And it's going to be all of your free time. It's going to be, your time not doing cases on the clock. There's going to be extra cases or with extra services, or going to a different hospital. There is an investment being made here. So it's very important that the hospital realizes that you're investing in them just as much as they need to invest in you. So in my world, my opinion is, if the job requires this skill, they should be paying you for this if they don't have someone more qualified who already has it. If I'm looking from the employer side of things, if someone over here is standing saying, hey, I already do this skill, I can already take vein without having to be proctored, I'm good to go, why wouldn't I want to hire them, right? Experience is a lot easier to hire because it's not an unknown if they're capable or not. They've obviously proven they're capable. But the problem is you have to retrain those people to not have the mistakes that the last surgeon taught them, because everybody's going to have that little way that they like to do things. So you're seeing a lot more people wanting to be trained from the very get-go, just so it's that particular surgeon's style, and that's okay. So all that to say, that's a little bit about my story. Hopefully that kind of helps put it all together in what I would be thinking about if you want to go into a job like this. Don't be afraid to ask if they have questions about it. One of the best things you can do is just take all the information you can get, talk to Tanya Nazaroff and say, hey Tanya, I got some questions from this one surgeon. I want to go into this job application or job interview, and I want to have the information. Can you send me some stuff? They'll send you all the paperwork. And I presented that stuff. It looked really nice. I said, hey, this is what the training looks like. This is what the experience is like. And quite honestly, that's what they needed to see, right? They want an executive summary that shows them all the nuts and bolts of what the training looks like. And that's what makes that sometimes go, okay, sure, let's do this. This looks good. As opposed to, I don't know, it's kind of nebulous. What is it? So don't be afraid to reach out to NIFA. They're resources for you. All right. Well, thank you, everybody. It's a pleasure chatting with you. If you have any other questions, feel free to reach out. This information is the best way to get a hold of me. But if you have any other questions, feel free to reach out to Kevin at NIFA. Make sure if you have questions about curriculum for Dean, check out his after hours. I'm sure he has one coming up. He's a great guy to talk to, super fun. For Chris, I'd say that's going to be the best person to talk to if you're still on here. But thank you for your time. It's been a pleasure, and we'll talk to you soon.